Bună seara și bine v-am regăsit la webinarele Better Medicine Zenyth. Sunt Georgeta Alexandru și mă bucur să ne revedem, iată, la primul webinar din acest an. Astă seară, după cum știți, suntem onorați să avem alături de noi un invitat deosebit. Îl avem alături de noi pe doctorul Kamyar Hedayat, medic și cercetător american, autoritate internațională în domeniul endobiogeniei. Unii dintre dumneavoastră sunt convinsă că îl cunoașteți, sunteți deja înscriși la cursurile de endobiogenie susținute de doctorul Hedayat. Ceilalți care nu îl cunoașteți, îl veți cunoaște astă seară și poate că veți decide să vă înscrieți la cursurile pe care le susține doctorul Hedayat. Alături de noi astă seară este și Alexandra Morărescu, naturopat și coordonator pe România al cursurilor de endobiogenie. Alexandra ne va ajuta astă seară cu moderarea acestui webinar în limba engleză. Înainte de a-i da cuvântul Alexandrei, aș avea câteva precizări legate de desfășurarea webinarului din această seară. Webinarul, după cum am anunțat, se transmite simultan pe platforma de webinare Webinar Geek în limba engleză și simultan transmitem webinarul pe YouTube, unde avem asigurată traducerea în limba română. Așa cum am obișnuit la webinarele noastre, la final vom avea o sesiune de întrebări și răspunsuri. Așadar, dacă aveți întrebări pe parcursul webinarului, ni le puteți scrie ca de obicei în chatul privat pe Webinar Geek, iar cei care ne urmăriți pe YouTube o puteți face în secțiunea de comentarii din YouTube. Urmând ca la final Alexandra și doctorul Hedayat să răspundă cât mai multor întrebări. Așadar, să le urăm bun venit alături de noi pentru prima oară la webinarele Zenyth Better Medicine, Alexandrei Morărescu și doctorului Kamyar Hedayat. Hello and welcome, Alexandra and Dr. Hedayat.
Thank you, Jetta, for the introduction. The subject approached today by our guest, Dr. Kamyar Hedayat, is anxiety, focusing on the endobiogenic perspective. Endobiogeny is an approach to medicine that is rooted in the modern language of science and based on a whole systems approach to integrative physiology. The goal of clinical endobiogeny is to return the physician to his or her place as a healer and the bringer of health, not just a manager of illness. Endobiogeny was developed by Dr. Christian Durafort in France throughout the 1970s and 1980s. Along with his practice partner, Dr. Laproise, a set of teachings were developed and taught throughout the world over the last 45 years. Dr. Hedayat apprenticed under Dr. Laproise and has been responsible for the systematization and expansion of the endobiogenic concepts, being the author of 4 book series on this subject. Dr. Hedayat was trained at Stanford University in pediatric critical care and was director of intensive care and integrative medicine, where he created the first holistic pediatric intensive care unit in the United States. He has been practicing endobiogeny for the nearly 20 years in the outpatient setting. He is the Chief Scientific Officer of Systems Biology Research Group, Course Director for Science of Endobiogeny and Clinical Endobiogeny, Chief Architect of the GEMA Biomarker Analytical System, and Formulator of Endological Line Remedies. Currently, the enrollments for Clinical Endobiogeny course are open, as Clinical 1 course starts in March 2026, and Clinical 2 is scheduled for 2027, where Dr. Kamyar Hedayat is the main lecturer. The Romanian medical cohort, being over 50% of the total number of students in the course, will have the privilege of having Dr. Camelia Obor as teaching assistant, and she will present the case studies in Romanian for our group. With this being said, please join me in welcoming Dr. Kamyar Hedayat.
Thank you, Alexandra, for a very kind introduction. Thank you, Jetta, for organizing this. And of course, thank you to Paul for his commitment to better medicine and the vision he shares. And thank you to Bogdan for the technical assistance. I'm so happy to be here with you today and to share some insights into anxiety. The title of this work is Anxiety, More Than a Psychological Imbalance, A View Towards Neuroendocrine Adaptation. Let's go into this a little bit further and see what this means. Today we're going to talk about global living systems theory and endobiogeny. We're going to define anxiety for the purposes of this talk. We're going to introduce and make a fine distinction between the concepts of physiopsychology and psychophysiology. We're going to demonstrate how you can make a rational, objective, and numerical physiologic assessment of anxiety tendency and develop a rational treatment of the anxiety terrain. Let's get started. Global living systems theory is an overarching approach which includes the theory of endobiogeny and is the basis for the vision that I'm going to be sharing with you today. It characterizes how life organizes and manages itself coherently. It's a formalization of systems biology thinking with the clinical specificity of endobiogeny, and it's a person-centered approach to medicine. So we're looking at the whole person and the experience of being alive as a human being, and not just purely cellular metabolism or biology. As far back as 1938, the psychiatrist Manfred Sacco, who developed something called insulin therapy for psychiatric disorders, wrote that it has become apparent that in the solution of these problems, psychiatry will be brought to medicine, and medicine will come to psychiatry. I think Dr. Sacco's vision was very prescient. It was far ahead of itself. And even this many years later, almost a century later, we still have not been able to fulfill his vision. But I believe with this new model of anxiety, we'll get closer to that. So let's talk about a physio-psychological approach. Many of you have no doubt heard about psychosomatic symptoms or psychophysiology. This branch of research is based on the concept and the perspective that certain genetic variations in neurotransmitter receptors and receptor subtypes and genetic and epigenetic modifications of neurotransmitter degradation affect the physiology. So this is psychophysiology. This is looking at how neurotransmitters affect physiology and how certain conceptual aspects of personality, our framework for looking at the world, affects our physiology. And a lot of this work has to do with a correlation between, let's say, stress or anxiety and the immune system, specifically looking at things like interleukin-6 or sometimes cortisol. But from our perspective, from an endobiogenic perspective, while this is absolutely part of the picture, psychophysiology, there's a very important body of evidence which demonstrates that there is an even more important part, which is physiopsychology, which is how the peripheral functioning of the neuroendocrine system and immunity can secondarily affect neurotransmitters and how we perceive the world. So it's really a bidirectional relationship. So for the purposes of this talk, I'm defining anxiety as worry with a sense of fear or dread. So worry is a mental response and fear and dread is an emotional response. So when both of these are present, we can consider this a state of anxiety. And physiometabolism the way physiology affects metabolic function can play a role in susceptibility to anxiety. So ultimately, the model that I'm presenting today is a bidirectional cascade of events that looks something like this. There's a mental perception we have. We have a belief system, a hierarchy of values of what we think is good or bad, what we want to embrace or have happen, and what we're afraid of happening. And this mental perception leads to an emotional response, an emotional reaction. We say, oh, this is good, it's wonderful. This is bad, it's terrible. And as we've established from the science of psychophysiology, yes, emotions, perceptions change the neuroendocrine system. There are fluctuations in the sympathetic nervous system, in noradrenaline, in dopamine, in cortisol. But what happens beyond this stage? Depending on how the body responds in the neuroendocrine management of metabolism, for example, if you have a rise in cortisol and a rise in thyroid stimulating hormone, TSH, and an increase of inflammation in the brain, that's been demonstrated to correlate with greater emotional lability, especially if the brainstem is inflamed as well, because then there's a greater output of noradrenaline, which can play a role in emotional lability. The more emotionally unstable a person is, or the more intense their emotional fluctuations are, the greater their mental distortions tend to be. Because when we already have a sense of panic or fear or dread, we're not able to think clearly and properly analyze what is really happening in our environment. Those mental distortions lead to a new emotional reaction, which then installs a neuroendocrine anxiety terrain. So in other words, what began as a temporary or short-term psychophysiologic response up here becomes a bidirectional cascade that leads to a type of physiologic tendency towards anxiety. And maybe some of you have had patients who say, I feel this anxiety in my body, and I don't know why, because mentally I don't feel anxious, or I start to feel anxious, but there's nothing to be anxious about. This is one of those classic examples of how just a pure neuroendocrine and metabolic imbalance can cause people to interpret these signals as saying, oh, my body feels anxious, I must mentally feel anxious too, and I'm going to find something to be anxious about. Why is it important for us to even explore this model? Because on one level, it is so pervasive. And on the other, because everybody knows people are anxious, and anxiety is one of the most common psychiatric illnesses, if not the most common. But the reason it's important to develop this model, which takes anxiety, which is a phenomenological event, people feel anxious at a mental level. We need to take it out of the phenomenological domain of psychiatry, which only uses questionnaires and impressions, and bring it into an objective physiologic method of determination. Because studies show that there's very poor inter-rater reliability between standardized questionnaires and the DSM manual. So there's less than 40% agreement between these two. That means that using the most official and authoritative ways of diagnosing anxiety precisely does not have good agreement. We need something more than the subjective phenomenology of asking questions and relying on people's insights. Because this is a very pervasive problem. Throughout our lifetime, up to 30% of people are going to experience anxiety. The majority of them are women. And in the United States, for example, it has a massive cost, over $42 billion in healthcare costs, and that was back in the 1990s. The other problem with the way that we're diagnosing anxiety is that we may be misdiagnosing something else, like a primarily physiologic imbalance, as a primary mental imbalance, and over-relying on benzodiazepines. And the challenge with benzodiazepines is that 36% of patients fail to respond to them at all. And those who do respond, they have an 85% failure rate to weaning off of their benzodiazepines at some point in the future. In fact, according to the studies in addiction, there's a higher success rate for people to stop using heroin than benzodiazepines. So if we don't need to use benzodiazepines because it's not the appropriate intervention, because it's not the primary causative level of anxiety, it would be better to avoid it. Other studies have noted that cognitive decline persists for several years after successfully discontinuing benzodiazepines. So what are we looking at in this endobiogenic and global living systems theory approach to anxiety? We're looking at a roadmap that includes all of these factors: hormones, neurotransmitters, nutrition, microbiome, genetics, epigenetics, environmental and psychosocial events such as trauma and coping patterns, as well as fundamental notions of personality. Now today, we're just going to focus on these top three factors. But if you're interested in reading more about these, I have a chapter I've written in a book on systems theory, and I can share a link to that at another time. So I won't spend too much time talking about this, but I just want to review the evidence that anxiety, there is a genetic component for sure. And if your parents were anxious, if your siblings were anxious, if your grandparents were anxious, you're more likely to be anxious. But there's also this hologenetic effect, which is how genes can be modified by epigenetics and environmental factors. There's also maternal-fetal interaction, because studies indicate that if mothers are experiencing greater psychosocial distress during pregnancy, the child is more likely to also experience anxiety or depression in their childhood. And then another factor that we want to keep in mind, but we won't explore in detail today, is something called adverse childhood events, or ACE. And these have, there's a specific definition for what constitutes an adverse childhood event. And these events have been shown to be very good predictors not only of anxiety as an adult, but also other chronic health issues and reduced mortality. There are medical and surgical factors that you want to keep in mind, nutritional and lifestyle, such as absolute deficiencies, but also insufficiencies, where vitamins, minerals, and amino acids are technically in the normal range, but not in the optimal range for the individual patient. There's also good evidence to suggest that an imbalance in the gut microbiome can also play a role in anxiety. In fact, there was a child I was treating for intrauterine cancer, and I was treating the child postpartum. And it took about 2 or 3 years for the child to be successfully treated for the cancer using standard approaches and endobiogenic support. But through this distress, the mother developed a very severe case of anxiety. And what ended up completely resolving her anxiety was regulating her gut microbiome. So I definitely want to encourage you to not underestimate the impact of a dysregulated microbiome. Insufficient sunlight, pollutant exposure, psychosocial interactions, institutions, culture are all going to also play a role in anxiety. So the endobiogenic approach and the global living systems approach is to take not only a whole person, but a truly global sense to the approach to anxiety. So at the biological level, we have microscopic factors like genetics and epigenetics, and we have metabolics. We can talk about metabolic psychiatry at this level, biochemistry, nutrition, the microbiome. But we don't want to just stop there. We also want to look at the mesoscopic level, at the role of the immune system and the hormones, especially cortisol and thyroid hormones, in inflammation and in altering neuronal stability. And we also want to look, of course, at central, hypothalamic, and pituitary hormones, neurotransmitters as well. But global living systems and endobiogeny go beyond that to also include phenomenological events like personality, family dynamics, trauma, societal and cultural influences, and cosmobiologic and environmental impacts as well. Because studies indicate, for example, that solar flares can lead to distress and behavioral outbursts, and so can certain phases of the moon. So, for example, studies indicate that men tend to present to the emergency room in greater numbers around the full moon, and animals tend to bite people more during the full moon, and women tend to present and to call, say, suicide hotlines and feel more distress during the waning phases of the moon. So we can't rule out the fluctuations in solar, lunar, and geomagnetic activity as having some effect on our physiologic stability. Let's talk about the core factors that we're going to be addressing today in our bidirectional model of psychophysiology and physiopsychology. The first and probably the most fundamental is excessive noradrenaline activity. Noradrenaline is the neurotransmitter of the first branch of the sympathetic nervous system called alpha sympathetic. You can see here in this blue circle that noradrenaline is produced in a group of cells in the brainstem that are called the locus ceruleus, or LC for short. And that's why I mentioned the importance of brainstem inflammation and how that plays a role bidirectionally in physiology, because noradrenaline stimulates cortisol and the thyroid system and the immune system to generate more inflammation. But it also works in the brain in all these areas, in both the thalamus and the frontal cortex. It stimulates the master hormone regulators and the hypothalamus and the pituitary as well. So when noradrenaline levels go up, there's a higher signal to noise ratio, which means that people tend to be overly sensitive to their environment. They might over-perceive a small sound and become startled by it, whereas people who have optimal levels of noradrenaline will filter out sounds that they don't need to pay attention to. This false positive arousal, just being overly sensitive and overreacting, is part of the anxiety terrain. It leads to the higher environmental sensitivity and greater afferent input. And it also reduces feedback inhibition. In other words, the higher your noradrenaline levels are in the brainstem and throughout the brain and the body, the harder it is for you to calm yourself and to get back to a stable state. And so this is going to be playing a role in sustained sensory awareness. Also important for our model is understanding that noradrenaline inhibits GABA's inhibition of neuroexcitation. So GABA, as we'll talk about in a moment, is the primary calming neurotransmitter. And noradrenaline suppresses GABA and doesn't allow it to keep the brain as calm as possible. So when we look at GABA, we see that it's produced in this area of the brain here, and it's working in almost all the same areas that noradrenaline is. So they're in a constant dialectic with each other. So it's the primary anti-anxiogenic factor, and it inhibits histamine as a neurotransmitter in the brain, and TRH, which is the master thyroid hormone produced in the hypothalamus. GABA inhibits all major areas of the central nervous system. And so when we look at the two together, we can see how closely they mirror each other and how higher levels of GABA can reduce noradrenaline, but higher levels of noradrenaline are going to reduce GABA. The third factor we're going to look at in terms of psychophysiology and neurotransmitters is serotonin. Many of you are familiar with serotonin for its effects on mood and its role in depression, but serotonin also plays an important role in anxiety or the prevention of anxiety based on how well calibrated serotonin levels are. And that's why many professional societies around the world actually recommend selective serotonin reuptake inhibitors, or SSRIs, as the first line of treatment for anxiety instead of benzodiazepines. What I want to bring to your attention are these behavioral effects of serotonin on mood, perception, and memory, because this is going to be an important part of the anxiety terrain. When people are ruminating or reliving traumatic events from the past, they experience anxiety just thinking about these past events, and they tend to be more likely to project a negative past experience onto their current experience and actually create the very bad outcome that they were trying to avoid in the first place. So understanding serotonin and GABA and TRH's role in memory is going to be very important to our therapeutic selections and how we manage anxiety at the root cause level. The other effects I want to bring to your attention today would be these other symptoms that are comorbidities with anxiety. Motor control, so when we talk about tremors and people being more excitable, jumping physically, getting startled, but also cerebellar regulation and the circadian rhythms and the sleep-wake cycle. When we think about people suffering with anxiety and insomnia at the same time. And serotonin is produced here in the raphe nuclei, also in the brainstem. And it also shares many of the same pathways with noradrenaline and GABA. And then respiratory drive, body temperature, and the regulation of multiple organ systems are also affected by serotonin. So when we think about the somatic expressions of anxiety symptoms, we can appreciate that serotonin is one of the factors playing a role in certain symptoms in certain people. Now, I'd like to talk about TRH, which is a hormone, but it's more accurately a neurohormone because it's a hormone and a neurotransmitter. It functions fundamentally as a neuromodulator, and it accelerates the rate of perception, planning, association, and action. It accelerates neuronal metabolic activity, and it plays a role in anxiety. So the higher your TRH activity is, the more you tend to feel anxious. And specifically, TRH colors your anxiety. It brings greater associations and catastrophization, where people think about worst case scenarios, and then they stop breathing, they hold their breath, and they are just totally lost in thinking about the worst thing that could happen. That's TRH that plays an important role in that. Now, as you can see here, when TRH acts in the frontal cortex, it's going to affect dopamine levels and play a role in paralysis by analysis. This is where people overthink what's going on, and they're so overwhelmed by all the scenarios and possibilities that they think about that they can't make any decisions. When TRH is acting in the hippocampus and the amygdala, it's going to promote more vivid experiences of past traumatic memories, and it's going to help create new traumatic memories as well. When it works at the level of the suprachiasmatic nuclei, the retina and the pineal gland, it's going to play a role in disrupted sleep, in very vivid or disturbing dreams. As in its role in the spinal cord and the cerebellum, it's going to play a role in hyperarousal, pain, and tremors. Because TRH stimulates TSH and T4 in the thyroid, and that can play a role in tachycardia and inflammation associated with anxiety. And TRH doesn't stimulate cortisol from the adrenal gland, but it does increase the rate of cortisol binding to its receptors, so it amplifies the effects of cortisol without changing the amount of cortisol that's being excreted. And then finally, TRH acts on the pancreas by increasing glucagon activity, and that raises glucose, and that leads to inflammation and dysbiosis, which can also play a role in anxiety. One last factor that we'll talk about today that's really important for our model is histamine. While we all immediately associate peripheral histamines, histamine released from mast cells, with allergies, I would say that an equally or more important role of histamine is as a hypothalamic neurotransmitter. And again, you see that histamine produced in the hypothalamus is distributed and plays a role in pituitary function, in the frontal cortex, throughout the entire neocortex, the cerebellum, and all the way down the spinal cord. So it has very profound effects, such as arousal and alertness. That's why first-generation antihistamines like diphenhydramine cause drowsiness in people, because they suppress histamine's ability in the central nervous system to maintain arousal and alertness. So histamines play a role also in cognition, in learning, and memory, in traumatic rumination, and mood. And so the higher your histamine levels in the brain, not from the mast cells, but directly released in the brain, the more it favors anxiety states and traumatic rumination, and pain perception is augmented. So I'm going to show you a model with an animation now of the neuroanatomy of anxiety. We're going to start here in the brainstem, represented here in the light blue color. Remember, the locus coeruleus is that collection of cells that produces noradrenaline, and this is where the story begins. So noradrenaline stimulates TRH in the hypothalamus. TRH stimulates the release of histamine as a neurohormone. Histamine sustains TRH's stimulation of itself. Now, at this point, our only hope of balancing this cycle, this cascade of arousal from becoming hyperarousal, is the role of GABA for relaxation. And GABA will also calm the entire limbic area in this process of memory consolidation, emotional response, and memory recall. But as you can see here, look to your right, noradrenaline inhibits GABA, and we start to lose that control, and we go through an upward cycle of excitability. Now, TRH plays a role in memory recall and how vivid it is, And noradrenaline plays a role in the emotional responsiveness, and histamine plays a role in memory consolidation. This is how traumatic memories are formed, and there are associations. And at the same time, histamine 1 and histamine 2 receptors will prolong the activity of noradrenaline. And noradrenaline stimulates the corticotropic axis, so CRH, ACTH, and eventually cortisol. And TRH increases the binding of cortisol to its receptors, whereas here the only hope we have of slowing this process down is healthy levels of serotonin from the raphe nucleus, also in the brainstem. And cortisol plays an important role also in the limbic area and the amygdala in terms of perception of fear, of neuronal stability, inflammation, and traumatic memories. And then finally, TRH, of course, has this classical endocrine function in that it stimulates TSH, which stimulates the production of T4 in the thyroid, and TRH stimulates the conversion of T4 to T3, and both T4 and T3 can play roles in anxiety as well. So we've now completed this model of physiopsychology and psychophysiology. And now the question is, how can we come to some type of objective numerical way of evaluating the physiologic factors which make you more susceptible to experiencing anxiety? Because our goal is not to eliminate the phenomenological approach, but to expand it to not only rely on questionnaires and the subjective experience of the patient or the subjective observation of the physician, but to introduce a third factor, which is the objective numerical measurement of biomarkers. So let's look at the evidence together. There's evidence which indicates that the neutrophil to lymphocyte ratio, which is an indicator of systemic inflammation, correlates to anxiety and other psychiatric conditions such as depression and schizophrenia. And another qualitative assessment of the immune system, specifically monocytes and lymphocytes in a ratio, has been associated with neuroinflammation and also with anxiety, including anxiety in children and a tendency to harm oneself. Now, our group, in Endobiogenie, Dr. Durford developed a cortisol index, and our group at Systems Biology Research Group has conducted several studies validating this index, and we found it to be a good indicator of systemic inflammation, immune activation, neuronal destabilization, and to be correlated with anxiety as well. So here, for the first time in the history of medicine, using only parameters derived from a complete blood count or a hemogram, we can start to look at some screening factors that are associated with anxiety according to various clinical studies. So at SBRG, Systems Biology Research Group, we have a testing platform called GEMMA Bioanalytics. And using only this CBC with differential and platelets, we have developed an anxiety tendency score, which looks at these factors to determine if there is a tendency within the physiology towards anxiety. And if it's present, there's also an endobiogenic anxiety questionnaire that takes into account psychological experiences of anxiety and somaticizations that you can use. And there are both pharmacological and non-pharmacological treatments using medicinal plants, vitamins, minerals, amino acids to help balance the physiologic profile that can favor anxiety in a patient at the root cause level. including something that I pioneered, which is microdosing of lamotrigine. All right, so this is a sample of the anxiety panel level 1, and this is a case study that we're going to go over in a few minutes. But just using this screening panel, you can see that this patient has an elevated tendency towards anxiety, both in function, which means under stress, and in their quieter states when they're not under stress or pressure. There's a very elaborated explanation of what this means and what are examples of private and public settings where people might feel anxious. But it's saying that this person will probably feel a little bit more anxious in public settings than private settings, but anxious in both settings. And we can see why the score is elevated. All of the individual factors we've discussed that are based on clinical studies are elevated in this patient. So we have definite numerical and mathematical reassurance that the immune system is playing a role in systemic inflammation, in neuroinflammation, and hormones are playing a role with an estimated level of cortisol activity in this case, which is over 5 times above the normal range. And with this understanding, we can now very rationally and systematically select treatments, not based on what we think might be helpful, but what we are reassured based on the mathematical analysis is likely to be helpful. So, for example, the general anxiety tendency score will recommend standard of care treatments, as well as diet, a whole grain Mediterranean diet, which has been shown to be helpful in patients with anxiety. But then there are specific anti-inflammatories that are recommended. And, these different aspects of the immune system affect different parts of the brain. And so there are different interventions that you can use. And then there are specific interventions for different medicinal plants, vitamins, and amino acids that have been clinically shown to reduce cortisol activity. This is an example of the questionnaire that's divided into mind, body, and mind-body symptoms. There's a scoring system based on established practice in the field by scoring based on frequency of having these symptoms in the last 14 days. And then there's a guide based on the total score that the patient has. Then finally, this analysis offers a systematic explanation of everything I've spoken about today, and in more detail goes into the studies that were used to rely on these different biomarker analyses to come to these conclusions. But if we want to fully evaluate the entire global model that I've talked about today, we can order a more elaborate set of tests and order a more elaborate analysis called the anxiety tendency level 3. This is a full list of all of the labs you would require, and in the GEMMA testing system, it will guide you through those choices. So here we can look at anxiety tendency, which we saw in the screening test, but also determine the anxiety type, if it's situational anxiety or generalized anxiety. We can look at GABA endorphin balance, brain serotonin activity, cortisol, inflammation more extensively than we did in the first level. So we can look at cerebral cortex, brainstem inflammation, and systemic inflammation. So just as a quick review, in terms of what the higher level evaluation can offer, it's looking at the problem of not having enough GABA as a neurocognitive agent in the brain. It can evaluate the tendency of having insufficient serotonin activity. We're not measuring levels, we're estimating or modeling activity. So we have the brain serotonin index for that. That can play a role in dampened mood, fear, anger, hopelessness, and helplessness. And we can look at higher noradrenaline activities and neuroimmune function. And we can look at cortisol with the cortisol index, which also plays a role in inflammation and GABA depletion. as well as inhibiting serotonin. There's good evidence in the clinical studies to correlate, but not necessarily with causation, the relationship between inflammation and various psychiatric states. Oh, this is interesting. This is happening without me touching it, but anyway, all these are drivers of inflammation, and these are the results of inflammation. They've been correlated with anxiety, depression, insomnia. And we have the brainstem inflammation index. We have the cerebral cortex inflammation index, which is looking at free radical activity. And we have the neutrophil to lymphocyte ratio, which we've talked about. So if we come back to our model of anxiety, now let's take a new look by looking at the indexes or the evaluations you'll find in the level 3 analysis and where they land. So we have the brainstem inflammation, the serotonin index, we have the GABA endorphin, we have the cerebral inflammation, which is looking at the role of central histamine as a neurohormone. We have the anxiety tendency score, which takes into account the TRH factor. We have the cortisol index, we have the neutrophil to lymphocyte ratio to indirectly look at thyroid function. So I'm going to go on to the case study, and then we'll take questions at the end. So this is a 38-year-old woman. She's a nurse by profession. She has chronic generalized anxiety, which started at 14 years of age. And she presented with an acute exacerbation of her generalized anxiety disorder because she was in a motor vehicle accident with her twin daughters. These are the only children she has. They were 5 years of age at the time. They were born premature, and they had a 6-week stay in the neonatal intensive care unit. And that was traumatizing for her, and it was traumatizing for the daughters. So this motor vehicle accident, which did not involve any fatality or physical injury to the mother as the driver or the daughters, evoked an existential fear of death. And we'll see shortly why this fear of death and losing a family member was so significant for this nurse. But her current symptoms when she presented were hyperarousal, impaired spatial memory, impaired executive functioning, postural orthostatic hypotension and tachycardia syndrome, or POTS, and insomnia with frequent night waking. And her twin daughters were also experiencing intense separation anxiety as a result of the accident and the mother's, in response to the mother's anxiety. And their separation anxiety was so severe that the mother removed them from public school and started homeschooling them, which is permissible in the United States. So what is in this woman's past medical history? She has a history of Hashimoto's thyroiditis, and she was on treatment with 50 micrograms of levothyroxine per day. She was on an oral contraceptive pill, which is a combination of estrogen and progesterone. And she had 4 adverse childhood events, which put her in the category of having major adverse childhood events. Her mother was verbally abusive to her all throughout her lifetime. She felt unsupported by her mother, who was hypercritical and emotionally frigid. Her father died at 10 years of age, and she was told very abruptly and was not given initially any type of emotional support from her mother or anyone else in the family. And then when she was a teenager, her half-brother developed schizophrenia, and she lost him in a sense because he went in for institutional care. So that was kind of like another death, or certainly a loss of a family member in her life. So just going on and looking at some of the other aspects of our networked theory of anxiety, her coping style is conflict avoidance, and she starts to dissociate when she becomes very stressed. And she feels emotionally unsupported by her mother because her mother's hypercritical, and unsupported by her husband just because he's so busy with work. In terms of environmental factors, they were not present. In terms of diet, I believed it was playing a role because she was eating a inflammatory microbial disrupting diet, which is a lot of red meat with sugar, but she denied consumption of alcohol or tobacco. And exercise was not an issue. She was exercising 3 hours per week. And she had a normal body mass index, so obesity and an inflammatory terrain from adipose tissue was not likely playing a role. So what did we find on her analysis? The anxiety panel level 3 categorically determined that she definitely had generalized anxiety, which was clear also from her intake. But now we're able to see numerically how severe this is and what factors are playing a role. So her anxiety tendency score, I showed you earlier, it was about 8 times, over, almost 7.5 times above normal. And we see that she has a pretty significant insufficiency of GABA because the GABA endorphin balance is low. And her brain serotonin activity was extremely low. So actually modulating serotonin is going to be a higher priority than even modulating GABA, although clearly both of them need to be supported. Now, if we look at so this is the psychophysiology part of it, but when we look at the physiopsychology, we see that she has a lot of inflammation. So this is 25,000 was the score for cerebral cortex inflammation. Normal's up to 6. Her brainstem was inflamed. She had the systemic inflammation, and her cortisol was about 5 times above normal. So this is a great example of this bidirectional model of psychophysiology from her childhood and physiopsychology once this had become entrained or established as a physiologic coping response to every stressor in her life. Well, let's look at what the analysis recommended. It started out by recommending a standard of care, which is a selective serotonin reuptake inhibitor, but also complementing this with magnesium because of the important role that magnesium plays in the production of serotonin, and also using valerian and GABA as an amino acid symptomatically, along with liposomal turmeric. Also, a whole grain Mediterranean style diet was recommended according to the clinical evidence. Lamotrigine was also recommended, and I'll get to that. Various plants that work both on the neurotransmitters and the neurophysiology were recommended because they also have inflammatory activity. Glutathione was also recommended along with selenium to reduce inflammation, and inositol. Now, all these recommendations don't mean you have to use all of them. It just means that you can use some of them according to your expertise and your experience, and of course the patient's preference. With respect to the elevated cortisol, the system recommended lamotrigine at a low dose level of 25 to 75 milligrams 2 to 3 times per day. Some of you may be familiar with lamotrigine as an anti-epileptic. That's at the high dose. At a moderate dose level, it's used for emotional lability in psychiatry. What I found, according to the animal studies, the clinical studies, and my own experience in my medical practice, is that low dose and ultra low dose lamotrigine, even as low as 5 milligrams, 2 to 3 times per day, acts on the level of the brainstem to reduce the output of noradrenaline, which you'll remember is the starting point of both the neurotransmitter imbalance and the physiologic imbalances. So this is why I recommend lamotrigine in this low dose or ultra low dose. Because the cortisol was already 5 times above normal, the algorithm recommends a slightly higher dose, so 25 to 75 milligrams. Other choices for you to consider would be saffron, skullcap, wild lettuce, valerian, danshen, ashwagandha, magnolia bark, etc. So she agreed to start lamotrigine, and initially I only started her on 15 milligrams twice per day, so a total of 30 milligrams. Because she had the 2 small children and she was homeschooling them, I wanted to proceed very cautiously. Now, I find the side effect rate is less than 10% with these low-dose lamotrigines. But because she was anxious, we agreed to start at a lower dose. I recommended one of our Endologica products. Well, it's a combination health set called Healing Self. It has Seraphin, which focuses on the neurotransmitter aspects, Toniquel, which focuses on the nervous system and symptomatic relief of anxiety, anger, fear, and then Cataquel, which is for the cortisol and inflammation. So let's look at this in a little bit more detail. To regulate GABA, Seraphin has lavender mother tincture. To improve serotonin activity, it has saffron mother tincture. To calm down that TRH and traumatic memory recall, there's Lithy as a chemotherapy. To regulate inflammation, there's liposomal turmeric as a mother tincture. The Toniquel was acting to calm noradrenaline thanks to valerian. To improve GABA and reduce inflammation with German chamomile. To improve detoxification of all these inflammatory byproducts with milk thistle. And then the Cataquel was supporting noradrenaline, GABA, and cortisol with magnolia bark. And passion flower for the GABA, more GABA support. And mallow, which is Malva sylvestris for inflammation and insulin regulation. And sequoia as a chemotherapy to regulate cortisol and DHEA. And psychologically and physiologically, sequoia can bring a sense of grounding, of stability, and allowing people to anchor themselves more in their body rather than being so captivated by their fears. Other treatments she agreed to start were magnesium citrate, 100 milligrams per day. And you know, the dose was so low because all these other medicinal plants are going to be directly modifying all these factors related to neuronal instability. So using this approach of combining these medicinal plants and these smart synergies allows you to still use vitamins and minerals, but you can use them at more moderate doses. If you didn't use the plants, you would want to use much higher doses of magnesium or GABA as an amino acid or L-theanine, which is perfectly fine as well. Those that also can lead to good outcomes. She agreed to go on a pescatarian whole grain diet, so basically a Mediterranean diet but restricted to fish. And she agreed to avoid meat and sugar as an approach to reducing inflammation. She was referred to a cardiologist, and her postural orthostatic tachycardia, hypotension and tachycardia syndrome was unremarkable. She declined using a selective serotonin reuptake inhibitor. She said she didn't want to be controlled by medication. I also recommended a technique called EMDR, or eye movement desensitivity regimen, which has been clinically studied and proved to be effective in helping people separate from their trauma and not allow that trauma to create so much physiologic imbalance. At that time, at the initial time she declined, she felt that she didn't have enough time to go see a therapist because of all the care she was giving her daughters. Well, I want to show you 18-month outcomes. She had very good outcomes within a few weeks, but I don't want to give you the sense that really treating this profound anxiety with childhood trauma and re-traumatization in adulthood is always easy. You need to be patient and persistent and allow the patient to heal by fundamentally altering this disrupted physiology, which has sometimes been going on for decades when the patient presents. And instead of just telling you that she felt better, which she did, I want to show you objectively and numerically what improved and what we had to work on. Well, you can see right away that she was still categorized by the system as having generalized anxiety, and she was anxious. But subjectively, she was less anxious. And objectively, we can see that the anxiety tendency score completely normalized. That means that the physio-psychology part, the imbalance of the immune system and the hormones had improved to a high enough degree that that was not playing a role in her anxiety. And at this point, it was primarily psychophysiologic. We see that her GABA endorphin balance improved slightly. We needed to work on that more. She had a 7-fold increase in her brain serotonin, but it was still deficient. And again, she still did not want to use selective serotonin reuptake inhibitors, and that's okay. Again, when we look at the physiopsychological, we see she had a pretty significant reduction in brain inflammation, 50%, but it didn't resolve. So we knew we had to continue to offer her liposomal turmeric and adjust her thyroid medication dosing to reduce the brain inflammation even further. You can see here that the neutrophil to lymphocyte ratio completely normalized and her cortisol activity completely normalized. And this improved. What did we do during these 18 months? Well, she agreed to increase the lamotrigine after the first 2 or 3 months to 25 milligrams twice a day. And she agreed to start EMDR therapy, and she said that she felt more in control of her feelings and in control of the traumatic recall. The anxiety was less disruptive of her life and it was more manageable. She was learning to be less disrupted by her daughter's anxiety and to have less codependency with them. She had reduced brain fog, and therefore she had improved executive function. And she had less night waking, and it was easier for her to fall asleep. And she was able to use a deep breathing technique for self-regulation in the moment when she had a flare-up of her generalized anxiety. In conclusion, anxiety is a multi-dimensional problem. It includes personality and perceptual frameworks, but also neurophysiology, inflammation, microbiome, diet, family network, faith, society, and ultimately all these factors are related to physio-psychology as well in this bidirectional approach. Global living systems theory and endobiogeny offer a physio-psychological assessment and a psychophysiologic modeling as well that's mathematical and objective, that allows you to rationally select treatments based on the individual and unique determinants of disease for the patient in front of you, so you can treat the patient that has anxiety and not the anxiety the patient has. And the numerical longitudinal follow-up allows you as the physician and the patient to objectively determine what treatments worked and which treatments can be discontinued and what needs to be increased or modified in dosing. If you found this talk interesting and you'd like to learn how to use endobiogeny in your practice, I would encourage you to join us for our training. The Clinical Endobiogeny Level 1 course begins in March. That's next week. 2026. It's a comprehensive training program that applies the principles of endobiogeny directly to patient care. Join us for live interactive clinical training. If you can't join us starting in March, you can always take the course asynchronously. You can sign up in April and May at any time and take the course, but we'd love to have you take the live course, because then you can join Dr. Kamyar M for a Romanian portion of the training through clinical studies that are live where you can ask questions from her. In this course, you're going to learn a systems-based or whole person approach to chronic and complex conditions with a strong focus on pattern analysis and herbal therapies, as well as vitamin, mineral, and lifestyle approaches. This course is highly practical and designed for immediate clinical application on Monday morning in practice. I'm the chief instructor of the course, and you'll have Dr. Kamyar M and Alexandra to support you through it all. By the end of the course, you'll learn how to analyze neuroendocrine, digestive, immune, and detoxification systems, to interpret functional biomarkers for personalized treatment planning, to apply medicinal plants and therapeutics safely and effectively, and confidently approach complex and chronic conditions like adrenal fatigue, chronic fatigue syndrome, autoimmune conditions, inflammatory disorders, digestive, metabolic, and hormonal imbalances, stress-related sleep and mood disorders such as depression and anxiety is presented here. As I mentioned, we have hybrid learning options. You can attend our live lectures. We have 24 hours of didactic training, 24 hours of experiential training, where we show you how to read panels like the anxiety panel step by step, and 6 to 12 hours of case studies. You can watch or rewatch the videos at your own pace. All the reading material you'll need for my definitive textbooks are included, so there's nothing more to purchase. And you can choose to have discounted access to the GEMA analytics system at a student pricing rate. So you can scan this QR code to start testing immediately with GEMA. You can scan this for advanced training, or you can scan this QR code to schedule a session to learn more. Thank you so much for your time and attention.
I would like to take the opportunity to thank Zenyth for the continuous support offered to Endobiogenie to be promoted to the medical specialists in Romania. Before we take on the questions from the participants, I would like to mention the fact that Clinical 1 Endobiogenie course is open for registration, and the Romanian specialists have an exclusive offer facilitated by today's Zenyth event. There are 2 enrollment possibilities. For $600, you get access to the course, 6 weekend lectures, and additional case study presented in Romanian by Dr. Kamyar M as teaching assistant. And for $900, you get access to the course and GEMA biomarker platform, where you can upload the labs of the patients and uncover the root cause imbalance of their symptoms. So the first question received, is there a direct correlation between cortisol level and anxiety level?
I'd like to rephrase the question in the light of our model, which is to say cortisol can be very impactful on anxiety. I didn't go into the details of the receptor subtypes and genetic isoforms, but in my article, my chapter on the anxiety, I go into the details of that. Some people genetically and epigenetically are much more sensitive to cortisol in their brain. And for these people, cortisol can be very impactful on anxiety. For others, it's less. So it's an important role, but not the only factor we're looking at. And I also want to point out that people can be anxious with completely normal or even slightly low cortisol levels because of all these other physiologic factors, microbiome, circumstantial, family dynamics. There are many layers to anxiety, but cortisol is an important one.
Thank you. I do not understand how anxiety score is calculated. Could you give more details on this?
Sure. So the anxiety score was presented in both the level 1 panel for anxiety and the level 3 panel. The anxiety score is calculated using only the elements of a complete blood count or a hemogram. And it is calculated through the interactions of the neutrophil to lymphocyte ratio, the monocyte lymphocyte ratio, and the cortisol index. It's a product of these three.
All right. Next question. Could rhodiola help in anxiety?
Definitely. I mean, rhodiola is one of the great adaptogens. In fact, I think the word adaptogen was introduced to first describe the activities of rhodiola. I don't talk about rhodiola a lot, but I use it in my practice. Rhodiola can, in some people, have a stimulating effect and can induce a type of hypomania or aggravate anxiety, but only in a small percentage of people. So for that reason, personally, it's not the first plant I go to for anxiety unless the person also has depression.
Thank you. Next one. Could ashwagandha increase nighttime awakenings?
I would say quite the opposite. Based on the research and my experience, ashwagandha can help reduce nighttime awakening because it has anxiolytic activity and it physiologically creates an anchoring effect where a person is more rooted in their body and they become less overly sensitive to environmental stimulation.
Okay, next one. How do we differentiate the psychologically reactive anxiety from anxiety predominantly determined by biological factors?
That's precisely why I created the anxiety panel, to answer this question definitively. If you don't want to use our panel, you could do neurotransmitter testing, and you could do microbiome testing, you could do like metabolic and nutritional testing, and then you could look at all of these factors and combine them to deter. Oh, and then of course you could do like a 4-point salivary cortisol testing. You could do all these individual tests and combine them together and have some sense of that. Or you could just do the panel I mentioned, which is modeling rather than measuring the specific factors.
What is the order in which you recommend nutritional supplements? It starts with microbiome support.
So I'm not sure, are they answering their own question or are they asking me?
Seems like.
Okay.
Maybe they want your advice.
Well, from an endobiogenic perspective, the microbiome itself is reacting to a combination of these neuroendocrine imbalances, which while they're systemic, they're acting at the level of the intestines to create intestinal permeability, intestinal inflammation, to impair the functioning of the digestive glands and juices. And then diet, of course, is also important. So from my perspective, regulating the neuroendocrine imbalance and the diet are the most fundamental way to address microbiome support before probiotics. Because if you're only giving probiotics and you're not addressing the inflammation or the diet or the systemic factors, you're going to have to give probiotics indefinitely. But if you fundamentally regulate these factors, everything else will take care of itself. Because the body is much more intelligent than we are. So trust the body and just help it do what God created it to do.
What could be the maximum dose of GABA if needed, and how long?
I think that's a question for a pharmacologist in terms of maximum safe dose of GABA. I think if you're asking that question, I would ask you to take our course, because to me, the question an endobiologist asks is what is the minimum effective dose of GABA that I could use instead of what is the maximum safe dose. But if you want to ask me how do I dose GABA, if I'm going to use GABA as an amino acid, it's probably something like 50 to 150 milligrams up to twice a day.
And how long should the person take GABA to enhance adaptation?
Well, it really depends, because if they have ongoing stressors, like they're in a toxic marriage where their spouse is abusive, or they have a difficult relationship with, let's say, their mother, and that's ongoing, or there's something continuously stressful, again, unless you can help them change their attitude towards life and their response, you're going to treat them indefinitely. And it doesn't matter if it's a benzodiazepine or GABA or probiotics or my products or Zenyth product. It doesn't matter. You need to fundamentally help the person really sit in a place of stillness and say, I accept that this is happening, and I'm going to change what I can change, and whatever I can't change, I'm going to leave to God to help me with. When you do that, then you don't need any of this. But until you do that, you need some support.
So profound. Thank you.
You're welcome.
Related also to GABA, would you also address all the pathways to GABA, like B6, zinc, or just give directly GABA?
Well, when I'm prescribing GABA, it's almost always in some type of combination product, precisely, that has B6. And specifically, I use P5P, the activated form of B6, is I think that's important for GABA recycling from glutamate back into GABA, and also for production. Yeah, I like to use it in combination.
Should herbal treatments focus first on improving sleep or reducing anxiety during the day?
That's a good question. I think this is where it's really important to have a participatory relationship with the patient, because this is a bidirectional relationship. Disrupted sleep makes people more anxious. Anxiety prevents people from sleeping. So what my advice is, ask the patient what is more distressing to them, the inability to sleep or the anxiety during the day. Because, from an endobiogenic perspective, you're using the same plant. You're going to select the same plants that are anxiolytic, that are also soporific, or help them sleep at night. It's only a question of dosing. It's not really a combination. For example, the ashwagandha we talked about, and valerian, for example. Both of that, I would give more valerian at night and less valerian during the day, and more ashwagandha.
When you talk about neutrophils on lymphocytes ratio, the neutrophils are higher than the lymphocytes, or the other way around?
The higher the neutrophil to lymphocyte ratio is, the greater the systemic inflammation. So higher neutrophils and lower lymphocytes. There's over 400 clinical studies looking at the neutrophil to lymphocyte ratio, and all of them have some positive correlation to higher neutrophils and lower lymphocytes.
Do you also recommend the pregabalin or gabapentin small dose instead of lamotrigine?
I'm really not a big fan of pregabalin or gabapentin. People just tend to have so many side effects with them. I found lamotrigine to work really well at the level of the brainstem. You could use them, and if you do, at microdosing or small dosing, let me know how it goes. I'd be interested to learn something.
May I ask, how many distinct archetypes of anxiety does endobiogeny recognize, each requiring fundamentally different approaches compared to conventional medicine? I would greatly appreciate a brief clarification on the depth of complexity and individualization that endobiogeny can offer in this context.
There are many. I prefer to use the term phenotypes and subphenotypes of anxiety rather than archetypes. But I would say, the way that I look at it, there are fundamentally 9 archetypes of human beings. So there are 9 basic flavors to anxiety, because what we feel anxious about and how we respond is determined by the fundamental physiometabolic archetype that we live in. And then it's secondarily colored by other factors. For example, one type of person tends to over-rely on cortisol to manage stress, whereas another type tends to over-rely on thyroid hormones, while another type tends to over-rely on thinking their way out of a problem. So they're using a lot of dopamine and serotonin and noradrenaline as a neurotransmitter. Each of these types has a different quality to their anxiety, both psychophysiologically and physiopsychologically. But I don't think people need to worry about. These are wonderful conversations that I can't wait to have with you guys in a master class. The good news is when you study endobiogeny and using the GEMMA panels, you'll quickly identify the key components and you'll immediately know which products to use and how long to use them, because when you retest your patient, you'll see what's improved and what hasn't. Just like mine, I very humbly and honestly showed you that everything was not perfect in 18 months. We still needed to work on things, but that was okay because I knew we were making progress and I was encouraged to continue down this pathway.
Thank you. In immunology, higher neutrophils are also a sign of Th17 activation. So there's a similar interpretation about the systemic inflammation in the context of high neutrophils.
Yeah, thank you, Maria. Excellent observation, and I appreciate that validation. When I was a fellow at Stanford, I had the privilege of studying in the Herzenberg lab. The Herzenbergs were a husband and wife team of immunologists who did a lot of the pioneering research in actually differentiating all the different aspects of the immune system and pioneering the use of different measuring and visualization techniques. So the immune system holds an important fascination for me.
We have a question from Dr. Costin Militaru. Could LDN be useful as alternative to treat anxiety?
So LDN, if you're not familiar, is low-dose naltrexone. Naltrexone is a partial agonist-antagonist of endorphins or opioids. And so the theory is that LDN can actually stimulate endorphin or other types of opioid production, and that this leads to a type of neuroregulation. Well, there's no alternative to good treatment. There are ways of determining actually using, let me rephrase this. Yes, the answer is yes, doctor. I showed you the GABA endorphin balance index in the level 3 panel. When it's low, it means you don't have enough GABA relative to endorphins. When it's high, you don't have enough endorphins relative to GABA. When there's anxiety and this index is high, LDN is a very good choice. And I believe the algorithms will recommend it in that circumstance, the way I've written the code for the program.
Yeah. Thank you so much. I think these were the questions that we received today.
All right.
Thank you for your presence, Dr. Hedayat. It was an honor to have you tonight with the community, the medical community in Romania. So thank you, Zenyth, for organizing this webinar and for bringing endobiogeny closer to the community.
Thank you, everyone. I'm honored to be here.
Mulțumim încă o dată tuturor. Thank you very much again. La revedere, seară frumoasă și toate cele bune!